All right. I think it's 10:30 in Montana, so we will get started. Thank you and welcome to Big Sky Care Connect's annual conference. This is track 3, session 1, talking about let's talk about onboarding. So hopefully you're in the right session. I would like to introduce our moderator, Jason Webster, who will be introducing our panelists and taking us through this session. Jason?
Thank you. Welcome everyone, thanks for coming. Today our panelists include Big Sky Care Connect's technical lead, representatives from InterSystems, and Billings Clinic. We have from Billings Clinic, we have Jim Maloney. Jim has over 28 years of experience and currently serves as the application manager for Billings Clinic. Kevin Ferreter is from InterSystems. He's a project manager. He's responsible for health share implementations. He spent the last 20 years focused on implementing healthcare solutions. Swetha Nalakonda has 14 years plus direct experience implementing health information technology, in particular HIE. And she serves as the BSCC technical lead. And also with us for questions is Rachel Lieber, who is a client success executive at Collective Medical, and she'll be available for questions about BSCC's ED alerts. So let's go ahead and get started with the onboarding process overview. Swetha, can you give us just a high-level overview of what the onboarding process entails for the participant facility?
Sure, Jason. So it looks like we have a good slide here that outlines the process. So I will go through each of these boxes and explain what it entails. So once the PA and the BAA is signed by the participant, the outreach coordinator that is assigned to your project completes an intake assessment of the process. So basically, your outreach, that's where the outreach coordinator hands off the project to the technical onboarding team. So once we receive the project, we do an evaluation on the project and determine who is the EMR vendor, and depending on a couple of factors, assign the correct onboarding analyst to the project. Once the onboarding analyst is assigned, we schedule a discovery call and we complete what is called a technical onboarding checklist. So using that checklist, we determine a couple of things like what are your goals, what are you trying to achieve, how are you trying to see the data in Big Sky Care Connect, what are the feeds that you're trying to send and things like that. And so that initial discovery call is very important. And we also touch on a couple of things like, do you have resources available right away to start the project? Or are you dependent on your EMR vendor to do this project? So all these things are discussed and determined during the first discovery call. Depending on your responses, if you have resources to start the project right away, we set up a weekly cadence of a 30-minute onboarding meeting, and these meetings would serve as your weekly touch point to keep the project moving. So we schedule those, and that's when the actual project starts. So basically at that point, we start working on the interfaces. So when we start the weekly project is when we start building the interfaces, and these are working sessions. These are typical working sessions for your project. And we test the interfaces, and during the testing process, and basically I went directly from building the interface to testing, but it takes a long time, meaning it takes typically 6 to 8 weeks, depending on if the resources are available correctly on time and things like that. So once we complete building the interface, we test the interface. And for testing, what we do is we bring up the data in Big Sky Care Connect, and we also ask the participant to bring up the data in their own EMR system, and we do a comparison of the data, and that's how we complete testing. Once the data is tested and the project is approved to going live, we turn the project back to the outreach team, and they do the user account setup and the training. And once everything is done, we take the project to, basically we call the project live, and we do the maintenance that comes with it. And basically the project is kicked into the maintenance mode. That is at a really high level, how the onboarding process works. I know I went through it really quick, but it typically takes 6 to 8 weeks, depending on resource availability.
Okay. So what are the transport options, the connectivity options that are available with Big Sky Care Connect?
So for transport options, Jason, we have VPN. So typically for HL7 version 2 feeds, which are your ADT feeds, your lab feeds, your ORUs, your MDMs, we typically use a VPN connectivity. For your HL7 v3, which is your IHE, XDS.B or XCA, to send a CCDA, we use HTTPS, where it's a certificate-based authentication, and we use that method for that connection.
Jim, you've been through this process. What method did you guys choose at Billings Clinic, and what drove that decision?
Great question, Jason. To follow Swetha's comments, for all of our HL7 2.0 interfaces, we used a VPN. And for our CCDs, we're going to be using HTTPS. We've done that with most all of our interfaces are VPN based, and for continuity and support, it's usually the preferred method for connectivity.
Okay. So do we have any questions from the audience at this point?
Nothing in the chat box at this time.
Okay. We'll move on to interfaces then. Jim, what was it like what was your experience like, just to back up for a little bit, with the connectivity? Let's talk about each one, the VPN as well as the HTTPS interface. What was that like for you as a facility trying to pull off that project?
Good question, Jason. So for us, our connectivity is supported by one of our infrastructure teams that does wide area network support. They have a standard form that we exchange with whatever site we're setting up the VPN with. So in this case, with Big Sky Care Connect, we exchanged our typical VPN configuration forms. They set up the connectivity, then my team steps in and confirms connectivity with a ping test and a trace routes, just making sure that we can get to the receiving system. And then we use Telnet to ensure the ports are open before we actually make connectivity with our interface engine. And that process can take anywhere from a couple of days to a week, depending. We've had sites that have taken up to 2 weeks, but usually that's a pretty quick turnaround, and it usually can take place before the discovery call.
Okay, very good.
Jason, we do have a question from the audience.
Sure.
Cindy is asking, what is the usual time frame on this process?
I'm sorry I answered that already.
You read her
For
mind.
other sites, now honestly, for other sites, depending on how many hats the individual is wearing, because in our organization, we have division of labor across a lot of different teams, but some sites, the same person may be wearing 3 hats, and they may have a lot of other duties. So it can really fluctuate. The most important thing, though, is to have a coordination call during the testing, and try to avoid using email as the primary method for setting that up. When you're ready to pull the trigger, just get on a call and work through the bugs.
Yeah, agree completely with you. Getting on a call for VPN connectivity, basically scheduling the call right away, completes the connectivity quicker than going back and forth via emails for 2 weeks. So completely agree with you on that.
I have worked some projects where you just set up a call, and different people come and go from that call all day and into the night until they're finished with it.
Yeah. Does that answer the question? Was it the overall project time frame or just the VPN? I wanted to clarify the question, please, once, so we make sure we address that. Ayank? Usual time frame on overall process. Okay, I'm reading the question again. So on the overall process, we account for 8 weeks for including the VPN. And that is all hands on deck, meaning all teams should be equally committed to completing that interface. And one interface typically takes 8 weeks if we are all 100% involved. And there's always going to be 100% involvement from the onboarding analyst and the InterSystems analyst who is assigned to the project. If the participant is also 100% available, we can complete the project in 8 weeks. That is per interface, though. I want to make sure that is clarified. After the ADT, the rest of the interfaces can be worked in parallel. So typically, I would say those can be completed within 10 weeks if we are all focused and working on it.
All right. Cindy says thanks. That was what she was wondering about. So you guys answered her question. Thank you.
Shweta, would you say that it helps, hurts, or makes no difference if that participant's technology, be it Epic or Cerner or whatever, has already been connected through some other provider? Does that help, hurt, not matter?
Oh, it makes a huge difference, Jason, especially for smaller provider practices. I would not say so much for the hospitals, though, because for EMRs like Cerner or Epic or like the bigger vendors who do hospital system, they're probably on typically different versions and things like that. So it does not make a lot of differences in that case. But for provider practices who are on EMRs like Athena Health, like ECW, that makes a huge difference. So once Big Sky has completed the first connection to these EMR vendors, they typically build what is called a hub. And once that hub is in place, we can bring n number of participants very quickly into the exchange.
But at that point, then it's just a matter of testing the quality of the data coming from that facility.
Exactly. You're absolutely right. So we are just doing the data quality checks and pretty much typically getting to the direct step of testing, which is a couple of weeks worth of work, and we can take the provider live.
So moving on to interfaces then, let's talk a little bit about cost and what can a facility expect to pay for interfaces to their EMR vendor. Jim, let's talk about Billings Clinic experience first.
Billings Clinic is a little bit unique. Typically, when we need an interface that we can't build ourselves, we'll reach out to our EMR vendor, which is Cerner, and they typically charge anywhere from $5,000 to $7,000 per interface. We do have engineers on site that do the bulk of our development, and so for us or any of our affiliates, there is no additional cost for the development work.
And what would they count as an interface? Would an ADT be an interface, and an ORU would be an interface, and an MD?
Yeah, and in a project like this, for the HL7 2.0 or 2.0 interfaces, you're talking ADT, lab results, radiology results, transcription. So they would probably quote us about $20,000 for this project.
Oh, I'm sorry, Jim, go ahead.
No, and then the CCDs would be a separate stand-up.
Are those about the same price as the HL7 interfaces, or are they more?
And this is gonna vary a lot by vendor. For Cerner, we already own the product that they use, so the implementation service, I think we're between $7,000 and $10,000.
Shweta, what have you found overall with? I mean, your experience is a little broader. What has your research shown?
So, Jason, again, this varies very widely. The cost of an interface varies very widely, and it varies between if we're talking about a hospital EMR and also or a provider EMR. So typically for a provider EMR, what we have seen is it ranges between $2,000 to anywhere from $2,000 to 5,000 to 7,000. I know I threw three numbers in there, but trust me, it's a wide variety we have seen out there. And again, there's maintenance as well. And the maintenance would be somewhere between $100 to $150 to $200 per month, depending on the EMR vendor. And there are certain EMRs that are also doing this for free. Like there are a couple of EMRs that would build these interfaces for free, but that is rather rare, but we have seen that as well. For hospitals, again, that like Jim said, it completely depends on the model that they're using. So typically somewhere between 5,000 to 7,000 per interface is what you should account for, at least.
Ayang, is there information that you wanted to share? There you go on the
Yes.
interoperability.
Yeah, so we understand that some of our participants lack physical and human resources to achieve the connection, and we don't want that to be a barrier in accessing the statewide HIE. So Big Sky Care Connect has created a program to provide financial assistance to our providers. So through this program, you can be reimbursed for any out-of-pocket expenses related to the project. For example, the EHR vendor interface costs that we're talking about right now. You'll be reimbursed up to $35,000 for expenses related to outbound interfaces you provide, and up to $15,000 for single sign-on or direct query projects. You are eligible to apply for this funding as soon as we have a signed participation agreement and BAA from you, and the applications are reviewed in the order received, and funds are granted until the funding resources depleted. So there's definite advantage to signing on earlier rather than later. Reimbursement is available once the milestone work is completed and you provide us with proof of payment, well, invoices and such, and you submit those for review.
I have a question. The question is, go ahead and handle that.
Okay, how long about will those grant funds be available? What is your guess? Okay, Cindy, the grant funds are actually available until through September of 2021.
Okay. All right, so changing direction just a little bit. Let's talk about the kind of data that can be sent to, housed, retrieved from the Big Sky Care Connect. So Swetha, what kind of HL7 message can Big Sky Care Connect accommodate?
So Jason, for interfaces, basically we can handle multiple different interfaces. We can get HL7 version 2 and version 3 as mentioned previously. So for version 2, we can do ADTs, MDMs, labs, radiology, transcription data, and also immunizations. And immunizations we can do bidirectional, not right away, but in the future we would be able to do a query and retrieve on immunizations. And the other thing I want to mention here is Big Sky Care Connect can also receive a CCD. So we can receive a CCD either via xts.b, or we can do an XCA query, or also we can receive a CCDA via direct, which basically you can send it to a direct mailbox and we can extract that CCD from that mailbox and ingest it into our system. So there's multiple ways we can receive information. And this again would be handled during your technical discovery. So depending on your strengths and capabilities, on your EMR vendor strengths and capabilities, we can all chart out what interfaces we can build for this project and what interfaces you want to build depending on your goals.
Okay, thank you. So the next question, I think we have already covered this. So BSCC usually starts with onboarding with ADT feeds. How long does it take to complete the process, and what does it entail? I feel like we've already covered that sufficiently.
Yes, you want me to go through it, or?
Sure. Yeah, let's just take it through it again real quick.
Okay. So yes, we start the onboarding with an ADT feed because that is the feed that is building the patients in our MPI, which is the Master Patient Index, and we need that patient in the MPI to tie the clinical records to. So that is why we start with an ADT feed. There might be some use cases or edge cases where you cannot send an ADT feed, and the question might be, okay, what can we do then? So if you cannot send an ADT feed, I would request that you bring it up during onboarding. And we have different ways of basically creating the patient from a clinical feed, which is not typical or the normal process, but we can definitely explore that. And if there's an issue with sending an ADT feed. But 99% of the time we start with an ADT feed, complete that before we start working on the rest of the feeds simultaneously, like your lab feeds, radiology, transcription, and whatever feeds that you want to do. And Jim can basically attest to it. We are working on 2 feeds simultaneously right now. We are also in the final steps of completing ADT. So we work on all these parallelly, and timeline, 8 weeks minimum, including the VPN connectivity. Depending on all hands on deck, and this time frame basically depends completely on how involved everybody is on the project. So I keep stressing that, I know, but 8 weeks is typical, but we have seen projects kind of extend to 6 months as well because of issues that arise in data quality and data feeds and things like that. Jim, do you want to add anything?
Sure, go ahead.
No, you're right. Every interface, you'd think it'd be cookie cutter, but no 2 projects are the same. And a lot of times you'll get 3/4 of the way through developing an interface, and you get to the validation phase, and you start bringing in your end users, and that's when issues arise, and you have to go back 2 steps, make changes. And each interface, because we're able to develop multiple, even though one project or one interface might take 6 to 8 weeks, we can run parallel depending on available resources. But for me, the critical part of an interface development is the validation.
Can BSCC accommodate multiple interfaces at the same time and multiple onboardings at the same time? What is the capacity there?
Yes, we handle multiple onboarding projects at the same time. Right now, basically, we are set up to handle more than 20 different projects at the same time. I'm talking about 20 different participants, and with each participant, we can do multiple feeds in parallel.
Okay.
And that is basically, I threw out a number there. I know it's very extendable, meaning if we have more projects that come on, yes, we can. We're not putting a limit on it right now, so we can take up a number of projects. Jason, I'm hoping that answers your question.
Yes, it does.
Okay.
So just generalizing and summarize what we've just been talking about. And when we talk about ADT feeds, it sounds like there are options if you can't send an ADT message, but the most important thing is to get the patient registered, cycle through the EMPI before moving on, because we wouldn't, until we have a patient identity, we have nothing to attach any data to.
Exactly.
That's what I'm hearing. So are there, what do we do? Oh, wait a minute, sorry, jumping ahead. Do we have questions from the audience on interfaces?
Not at this time.
So let's switch and let's move over to Kevin and talk about security and privacy for a moment, and compliance. So let's first talk about separation of data, in particular between the data in the test environment and the production environment.
Sure. First of all, thank you. Let's first talk about environments. There are typically 4 environments that we have stood up for a solution like Big Sky: a test or a development environment, a test environment, UAT, and production. And all those environments are kept independent. The dev and test environments are usually set up and expected to not hold any PHI. So those are segregated from the other environments. And in fact, we don't even allow data to be transferred between a dev and test environment up to or down from UAT and prod. So there are technical safeguards put in place that just don't allow those two systems to even talk to each other. Once you get into UAT and dev or prod, now you are working in environments that would expect to have PHI. We do make sure that any connections to those systems are, we went through the whole testing process of the VPN and stuff, but we're also doing additional things like whitelisting of IP addresses to assure that, a customer's test system is, say, connected to the UAT system. The customer's prod system is connected to the live system in our solution. So there's multiple layers there for separating and keeping those environments separate so that we don't have an accidental placement of data within the wrong environments.
What about access to the environment? What security is there around the test environment?
Yeah, so actually all the environments have similar security in terms of access to them. For any of the technical development staff who are accessing them, they have to go through a Bastion server. So they're VPNing into an InterSystems environment, and then they're getting onto a Bastion server, which is a virtual desktop environment that is really all that they can connect to. And then from there, that environment then has access to, say, a test environment. So you're making multiple secure connections. First a VPN into the environment, then a connection into the Bastion host, and then only the Bastion host is able to talk directly to the environments themselves. And in fact, there's even security on those systems that don't allow uploading or downloading of data between those environments. Now, we do have infrastructure staff who have access, obviously they manage the data center. They're going to have access to those environments. When we do need to have something that is, say, being transferred from the Bastion host onto the server, it's actually, they're the only folks who can do that. So we have to go through a process to request data transfer, and then they are the only ones who actually do that data transfer. So there is a fair amount of protection that separates who gets access to those systems, how do they get access, and what level of access they get. And the main thing is providing folks who need access with a proper level of access to those systems so that you don't just have it wide open to anybody. Only the infrastructure folks would have that root access down into the hardware itself. Development staff would have to go through multiple secure layers to actually be able to manipulate the system itself.
Good. Okay. So let's talk about 42 CFR Part 2 data. 42 CFR Part 2 places additional restrictions over and above HIPAA on data, particularly for substance abuse data. How are you guys managing that data?
Yeah, it's an important topic that comes up with every customer. And I'll actually expand it beyond just 42 CFR Part 2 data. That is one category of protected data. But within Montana, there's also local regulations that has other categories of data that is sensitive as well. And the system has multiple ways to protect that information. So there are consent policies and access policies. So first of all, there'd be a role-based access that would even indicate whether a user would be able to access that data. So do they even have the right to see that data at all? And then there will be override capabilities in there that you have to attest that you have your consent from the patient for that data to be able to view it, and you have to go through a process within the UI to indicate that you do have that consent. So once you've done that, then the system does have the capability in terms of 42 CFR. We're managing that at a facility or department level. So that data is tagged as either coming from a 42 CFR facility, or it's tagged as coming from a department that would within a larger facility that would have 42 CFR type data. We also have code-based policies that would look at the individual codes that are on a record, and that would be applied, and that really applies more to the sensitive data within Montana. So, you know, here's HIV data. I'm going to forget the various topics that are actually considered sensitive, but, you know, we'll code base that to indicate that these are records that should not be shared unless the user has the right and the user has indicated they've been given consent to look at it. And all of those views of that data are audited as well, so that we all understand who has gone and looked at that data. And you can look at that over time.
Let me make sure that I can give this back, make sure that I understand what we're saying here.
Yeah, there was a lot in there, so please do.
Yeah, so we can categorize the data as Part 2 data. We know what is Part 2 and what isn't Part 2. We have, and not just Part 2, but any other category of protected data, we have the ability to configure and define.
Correct.
We can attach a type of credential or a level or some sort of credential that is required to access that data that is then assignable to a user. Do I have all that straight?
You are right on target. That's perfect.
All right.
So you have those two steps, and then the third step is that user would then have to attest to having the consent when they go to look at that data.
That was my
So
next.
we'll not,
Okay.
yeah.
So the consent is handled. So the clinician gets the consent. When they use the system, they're attesting that they have that consent, and all of that is logged in the system.
Correct. Yeah, all of that is audited, and it's that user having the capability and then doing the consent that allows them to then, it tells the system it is okay to show that data for that user.
So then once we have collected all of that access information, suppose someone comes along and says, hey, I want a compliance report. Who's accessed this data? How does that work?
So
We've got a special slide on that.
go to the next slide.
New slide? Here we go.
Yep. Yeah. So there are administrative reports within the system, and one of those reports is to look at the audit log and to be able to report on all sorts of events. But in this case, there's one that's particular to access to patient information. And in this case, we would be logging both the consent was put in, or was attested to, and that the user viewed sensitive data. So the system is set up to have these standard reports available. If the request was there, it would be a request that would be made to Big Sky Care Connect. The administrative users within Big Sky Care Connect have access to run these reports. So a request would be made to Big Sky, and at that point, the report would be run for the organization that was requesting it on the patient they requested it for.
I want to clarify just one point. You said who accessed sensitive data. All the data is sensitive, so I assume that means everything that they access.
Correct. So there would be a report that just said I accessed the patient. In this case, if it was sensitive data, there would be an additional record that said I had consent and I accessed sensitive data. So there'd be multiple sort of activities there that are audited when you look at patient data.
Young, do you want to handle the question now, or we have a question from the audience? Do you want to deal with it now, or do you want to wait for the next two bullets?
Actually, Jason, I'm not seeing a question
Either am I.
in the chat.
Okay, my bad. So, so next slide. My apologies. We're going to talk about, so there's a slide then, yeah, for privacy and security. What measures do we have in place to prevent hacking of the system? Let's talk about down to the hardware, how's everything protected?
Yep, so lots of protections in place that are around privacy and security. Before I even go into any of the details, I will say to folks, you can go out to the InterSystems website, so intersystems.com, and if you do a search for data protection, we do have a document out there that outlines the various aspects of, it's an overview document that will tell you here are the things that InterSystems has put in place to protect this data, including not just technical items, but what are the policies and procedures that are in place as well. So it does that at a high level to allow folks to understand the level of effort that's going into keeping the systems secure. You will see here right up front, we do have a high trust certification. So that is, when we look at it, we're looking at, what are the various levels of certification we can get that will allow us to ensure that we're secure. And high trust is one of the ones that we have gone out and gotten. Is for participants of Big Sky Care Connect, we can share the report from that. So that again, once you're a participant, you can have more detail as to what we've done. Technically, first of all, you'll see here encryption. The data is encrypted at rest, so everything that is stored is encrypted at rest, and obviously in transit. So we already talked about the VPN connectivity and the HTTPS connectivity. So any data that's in transit will be encrypted as well. We talked a little bit about some of the access management already, but the entire system is controlled by a role-based access. So are you administrative user? Are you a clinical user? You'll see here the next category is, are you a payer user? And then what, based upon your role or based upon your organization, what data would you have access to? Some of the other things you see here, in terms of, and I think we'll talk about this a little later, but you see single sign-on. Most importantly, again, how you're accessing the system will have multiple levels of credentials and different mechanisms for sharing those credentials based upon, are you doing a single sign-on or are you using the web-based portal? And all activity within the system is logged, and that's an ATLA log, which is, again, a log that is non-touchable. So, ability to make sure not only are we protecting the data, but if somebody's in there and looking at it, we know who's looked at it as well. And I think, if you look at the report that I mentioned early on, if you go and search for that, you'll also see things like what are our policies and procedures. So we talked a little bit about the access policies. How do we access the systems? So we have policies in place that say you can only access the system through a bastion host. There are also policies around training. So our employees trained to understand what it means to protect data and what it means to have privacy and security. So we'll also have annual trainings for the staff on these type of topics, so that not only do we have the technologies in place, but we have the right processes and policies in place to ensure that not only do we have technology, but are people doing the right thing.
And where is the data housed?
We have two data centers. The primary data center is actually just outside of Chicago in Oak Brook, Illinois, and the secondary data center is in Virginia. So we have those. Those are the two primary data centers for all of our health share hosted solutions. And, again, geographically dispersed so that we have not only high availability, but disaster recovery capabilities. And those are in secure facilities. Again, within the website, you'll see the level of access to those secure facilities. It's something where you have to be, you have to be identified beforehand. You have to sign in. There's no access without an escort. So not only do we have the technology within the solution to protect the data centers themselves are highly secure as well.
Very good. Do we have any questions from the audience at this point?
Jason, not at this time.
So Kevin, I have just one quick one. So I assume that you have intrusion detection, security event management type systems in place. Can you talk to us just a little bit, without giving up too many secrets, about how you watch devices across the network?
Yeah, and you're absolutely right. There are those sort of detection monitors in place. And really, at a very high level, those monitors are running. Any alerts that are coming off of those monitors are sending alerts to individuals on staff. So, a few of that is monitored on an active basis. If it's a security issue that pops up, it will, somebody will get paged or email, phone call. That's, it could, something like traffic is slowed down. That'll be more of a, okay, great, it'll alert. But if there's a security related alert, many bells and whistles will go off to make sure that somebody immediately looks at that situation and make sure that that we really are in a secure situation.
Jason, we do have a question from the audience.
Okay.
Cindy is asking, how often have you had to use the storage data? For example, how often has an HIE gone down?
You mean and have it recovered? Has it gone down and had to be recovered from backup?
I think so.
Yep. Okay. So yeah, I think I was interpreting it the same way. So how often have we had to utilize basically our disaster recovery processes to pull data back from storage and get it up and running in another environment? The good news is never. We haven't had that situation occur within our current production systems, but it is something that we do test out. Should say, I know this goes a little bit beyond the question itself, but it's actually not so much off our storage data. We do have an asynchronous mirroring to that DR site, so it is a continuous update of the data in the DR site with the goal of reducing how much time it takes between declaring a DR event and being able to have that DR system up and running. So just wanted, the storage data part of that kind of sort of triggered that in my head to mention that, it is designed to have the least amount of data lost if we go into a DR event and to minimize the amount of time to be up and running.
That was going to be my follow-up question to that was, how long does it take data on average to move from the primary site to the DR site? And, what can be expected or what is guaranteed and likely in terms of, point in time recovery or no data loss? How much data loss if the system is cut over? Because there's always something in flight.
Exactly. And to be honest with you, I don't know the number off the top of my head. I'd have to look at the contract to say what was in there. But it is designed to do a continuous movement of that data over. And that mirroring technology is, again, it's asynchronous. So it's just sending the data and not waiting for any responses back. It's fairly up to date when it goes over, but there is obviously some level of latency between the two data centers. But that's measured in a fairly small time frame.
We're talking like seconds to minutes, maybe.
You're talking seconds to get the data over, and you're probably talking. I won't even give a number. I'd have to look it up to say how much potential is there in terms of what transactions in flight.
Okay.
But I will, I will say, I actually will say from a data perspective, and remember as an HIE, most of the data is coming in. There are robust systems in place to capture all those incoming messages. So, in effect, those messages would be replayed. So from an inbound data perspective, you would really not have any data loss from that standpoint.
So basically, you'd have to have some kind of disaster that would completely destroy everything in the data center to even experience that. In other words, there is robustness within the primary and the backup system, and there's a primary.
Correct. Yes. Yeah, exactly. There's a high availability within both data centers, but independent. So not only would you have to have a major disaster, it would have to really impact the entire data center to see data loss like that.
Okay. Let's switch to user access. Swetha, how do users get access to BSCC's provider portal? What does that process look like?
Sure, Jason. So basically, for accessing data from the Health Information Exchange, we have 3 methods by which the data can be accessed. One of which is directly going to the provider portal, basically. So you can type in the URL, go to your portal, and access the portal from there. The other option is single sign-on. So we do support single sign-on from your EMR or your portal, wherever you are, directly. Basically, when you implement the single sign-on technology, with one click, you can go from your system and to the provider portal. So basically, a window would open up, and you can basically query and use the information in the provider portal. The third method is the direct query, which is, again, the xds.v query or the XCA query. So with this method, you would be within your native EMR system. So let me take an example of Epic here, because it's quite a common EMR. So let's use Epic here for a second. So if you're within your Epic system, there is backend integration between Big Sky Care Connect and your EMR. And when you click on a tab, which might say external documents or something along those lines, there's a query that initiates in the background and brings you all the information within that tab. So what you'd be seeing here would be a set of CCDs that Big Sky Care Connect would return, and you can open those CCDs and view them and go about it. So primarily there are 3 methods, and do you want me to expand on that or go anywhere from
here? Go ahead.
Jason, can you please repeat that? I'm sorry.
Yeah, sure. Go ahead and expand if you'd like.
Okay. So
in particular, the provider portal.
The provider portal is a role-based system. So basically, I think Kevin touched on it a little bit as well. It's a completely role-based system. So depending on what role you are using to log into the system, there are differences that you can see. So a higher elevated role would have access to 42 CFR data, access to break the glass and things like that, whereas a different role might not have that access. So it's completely a role-based system. And Jim, I think, let me turn this over to you to see if you want to add anything in there, because on the portal piece.
Well, as far as access, I think we're going to be using a combination of these 3 access tools. For the validation, we've been talking about using the provider portal, and for providers that are offsite, like locums, that would be an ideal solution. Once we get the embedded single sign-on in Cerner, then our providers will be able to launch from within Cerner. And for our CCDs, I'm imagining we're going to be using the direct query for the HIE, so that we'll be able to bring in CCDs.
So Jim, you guys are using a single sign-on for at least some of your solution. What can you describe to us what that's like for your users?
We haven't deployed the single sign-on for Big Sky Care Connect yet within our EMR, so I can't walk through the workflow very well for you right now, but that's our intention.
Okay. Kevin, would you like to chime in on the single sign-on option?
Sorry, had to unmute.
Okay.
Yep. So we do support a single sign-on option. and our intention is to, with many of the larger EMRs, is to be able to do that launch. And I don't know how technical we want to get, but it is a secure connection. Obviously, utilize tokens to ensure that the user who's logging on, we're getting the credentials from the existing system, and there's a whole handshake there, and ensuring that there's also a security certificate in place to protect that connectivity as well. So it is something that it helps keep a provider in their workflow. So it is an option that we will look to do, definitely strongly want to do to enable the benefit of the HIE information to be shared within the provider's workflow.
So the provider will be able to just log into their EHR system, and the EHR system issues them a hall pass, and they what? Then get redirected over to, or when they go to use the provider portal, they're already logged in. Is that how that works?
At a high level, yes. They will, the EMR will provide the security token that's required to ensure that, this is the person who's asking, and there'd be some sort of launch mechanism within the EMR itself. And they vary depending on the EMRs, but there'd be some launch mechanism that would say, okay, great, I'm in this patient's context. Now sharing the user's context and the patient's context, please go ask the HIE for the information on this patient, and not require an additional login to do that.
Okay. How about the direct query option? Is that, I understand that that's an XDS query?
It's one of two. It's either an XDS query or an XDA query, but it is the capability. It is the capability to basically be able to ask for the data to be provided, usually in a CCDA document format, and it's usually an on-demand view of what the system currently knows about that patient. So it is a way to, through an API, be able to pull that document and be able to share that within the EMR itself.
So let me make sure I have this straight. So I can do a query, and I can get an XDS document that is an on-demand, which is created on the fly from the already validated, already deduplicated data that is in the clinical data repository that is holding that longitudinal record. And I can
correct.
Conveniently as a deduplicated, consolidated CDA document.
That is correct.
That's really handy.
Yep. And then, it's up to the EMRs. Some EMRs will just show that as a document. Or you could even, some EMRs would allow you to launch the viewer itself. So you get the full sort of view of the data within the clinical viewer.
Okay.
So it runs a gamut in terms of what options are there, and it will be dependent upon what the EMRs can support.
So let's talk about, next slide, please. What data that the provider will be able to view. So what are we talking about exactly? We've been skipping around at high levels, and it's CDA and HL7 messages and whatnot. What data elements and what should the providers expect to actually be able to have available in the system?
So
Wait, we'll start with you.
Yeah. So basically, this slide does a good job at showing what data elements are available. So from an ADT message, again, we take all the demographic data of the patient. We also take the allergies, diagnosis, procedures, anything else that can come in an ADT message is taken and displayed in the portal. We also have mechanisms to ingest the lab data via the HL7 ORU feed or the CDA. So it does not matter where the data is coming from. It is a single view. So if you send a lab via CDA and someone sells a lab via HL7 messages, at the end of the day, it does not matter. All the data is available, should be available in the lab tab of the portal. The same concept holds true for radiology transcriptions and immunizations and things like that. So this is a single consolidated view of all the data that's coming in via different mechanisms into the system. So you can see allergies, medications, and we'll talk about medications actually in a little bit because we want to touch on how are we getting the medications data. We have something called the documents. Actually, this is the place where you see the transcribed notes, but this is also the place where you can see other documents submitted by other people, like your CDAs, or if the other point I want to touch upon really quick is we will have a connection very soon with the eHealth Exchange. So any documents that are coming back via that query would also be housed in the Documents tab. And the immunizations, procedures, encounters, demographics. So just trying to wrap up here. So we have a whole slew of medical information available on this page. And I'm trying to think, okay, let me touch on medications really quick. For medications, we are getting the data via Dr. First query that we have currently. So that is how the medication data in the medications tab would be filled. The other piece of information I want to touch really quick is we have Medicaid data in the system. So all that information is also broken and housed within these tabs.
Okay. Kevin, is there anything that you want to add to that?
No, I think that actually was covered well and hit all of the major areas of data that's stored within the system.
Okay, next slide, please. So direct secure messaging and CCD. So Shweta, tell us about other functionalities that are offered by the portal, in particular DSM and CCD.
Right, so we have not touched upon DSM till now. So I think, yes, so we have direct secure messaging that Big Sky Care Connect has implemented. The beauty here, though, is you need not go to a separate portal to access direct. So what we have done is, and I'm very happy about it, what we have done is we have integrated the direct secure messaging functionality into the InterSystems native platform. So it's a one-stop shop. Basically, when you go to your portal, you have the mail tab available. So when you hit on that mail tab, it launches the, it looks like your typical email, right? Like your Gmail account. So it launches your email and you can basically send CCDs from within the portal to anyone else who might be interested in this patient for transfer of care and things like that. So you can generate a CCD from the platform, attach it, and send it out. So that's really beautiful and a very useful functionality that we have built here with direct secure messaging. The other aspect of direct is now you're an EMR vendor, you have an EMR that has no functionality to build interfaces. So there are a couple of EMRs, and I don't want to mention any names here, but you might not have the ability to do your typical ADT feed or your lab feed and things like that. But the most common denominator for most EMR vendors is direct. And using direct, you can submit a CCD to to Big Sky Care Connect, and we should be able to take that CCD and ingest that into the Health Information Exchange. And what that would mean is your data is now in the Health Information Exchange, and you can view it in the portal.
We do have a question from the audience. She's asking if anyone in Montana fully implemented with this HIE yet, or even close, and where else what other state have you done this type of HIE implementation? So maybe Shweta, you can talk about our implementation and how close we are with the facility and getting this implemented fully. And then maybe Kevin, you can talk about the HIE implementations like this in other states.
Sure. So we are very close to completing a full implementation, and Jim is here, so I cannot say anything, but we are working with a number of facilities currently on building interfaces with them and on getting the data into the health information exchange. So like I said, we are very close, and I'm pretty sure the Ayang, please correct me if I'm wrong, but I think they have an announced date or close to announcing a date on the launch, but we have a lot of work that we have completed, like DSM is what I was saying. We have done the platform build. There is all the screens that we are showing you right here are from the live system, are from the system that we have implemented. So let me pause there and turn it over to Kevin to talk about implementation in other states.
Yep. So this HIE has been implemented in a number of states, and in terms of states themselves, it's up and running in Missouri, Texas, New York, Alabama. I'm going to forget some, but it's not just at a state level. In New York, it's actually powering several regional HIEs. In Michigan, it's powering a regional HIE. You'll also see it used within IDNs and healthcare systems as well as an internal tool to facilitate their connection to their internal systems, multiple facilities, but also external providers who might be partnered with them as well. So you're going to see this at quite a few sites that are actually running this HIE.
Okay. All right.
So there was another question that just popped up. So let me.
Yes, there is.
The question is, in those other states, do you ever get all providers in the community connected, including federally qualified health centers? The answer is no, you never get all providers, but you get all types of providers, including federally qualified health centers. Missouri is an example of a state where they have gone out and have connected up several of the FQHCs throughout the state, and we're focused on that because part of their mandate within as the state HIE was to not just make something that's available to the large providers or the large urban centers, but to make sure that they were touching on many of the communities within Missouri, which are small communities which may only have an FQHC as their primary center.
She says, thank you.
So BSCC, there's been talk about offering event notifications. What methods are available for subscribing to this function within the HIE? Is there a way to get alerts within the provider's workflow? And how do we avoid alert fatigue? Shweta, well, you can start with that one.
Sure, Jason. So you've heard it right. Yes, BSCC does offer event notification. The way you would subscribe to your event notification is by submitting a patient panel. So you can submit a patient panel that says, Dr. Smith or Dr. John wants an event notification, and this is the patient panel. He wants to be notified for patient XYZ for these conditions. So if I want to be notified when XYZ get admitted to an emergency room, for example, or when these patients are admitted to a hospital. So all these are different options. So we have admit, discharge, transfer, and emergency room notification. So you can pick and choose which notifications you want to be alerted to. So when you asked how do we stop alert fatigue, choosing the right alert type is the first one. And making sure your patient panel is concise, meaning you don't want to dump your entire patient chart from your MPI, or basically the entire patient list from your MPI, and say, I want alerts on all these patients. You probably want to choose your critical patients or your most important patients, or how will you determine who your most important subset of patients are, and submit a patient panel to that. Right now, we take the patient panels and we can give you a format, basically a spreadsheet format, or you can send it in a particular format, and we'll ingest it from the back end. And that's how we would have the patient panels, and we know how to trigger the right notification for the right doctor. The other question is, how do we embed this into the doctor's workflow, I believe. So there are three types by which you can, on how you can receive notifications. One is you can subscribe to notifications and you can receive them via direct email. So you can say, I want to get a direct email anytime there's a notification on the patient. So that is one way. Or the other way could be, I want an ADT message back to my interface. And the beauty of that method is when you subscribe and say, I want an ADT message, we would trigger an ADT message, and you can take that ADT message and ingest it into your workflow. Meaning, now you can take that and you can turn it around and put it in within your EMR, within the doctor's workflow, meaning you can do anything you want once you receive that message via an ADT. Or the third option is to receive a set of notifications via an SFTP kind of a model. So we would bundle up all the notifications for the day, and at the set frequency, send those back to you. Again, the same holds true. Once you receive them back into your interface, you can do anything you want with them. I kind of talk about it as dropping it at your doorstep. Once we drop at your doorstep, from there on, your interface team can build it out beautifully in n number of different ways.
So I can provide a patient panel on a spreadsheet.
Mm-hmm.
There's a list of subscribable events, is what I call them. The conditions that are defined within the system.
Mm-hmm.
Discharge from an ED, admitted to a hospital, whatever. And then I have choices as to whether to receive a DSM message, which is essentially an email, or I can access the portal and see them there, or I can simply receive a message back into my system, and I can control what I do with that, if anything, and have control of my workflow that way.
Mm-hmm.
Perfect.
That's correct.
Jason, we have another question from the audience.
Sure.
We have someone joined late and is asking if you can go over the interface costs again.
Yeah. Swetha and Jim, let's go back and let's talk about the cost of the interfaces. And let's re-answer that question.
Sure. So let me start. Again, the interface costs vary widely depending on your EMR, and even if you're a provider or hospital, because if you're a hospital, you maybe based on your contract, you have a different kind of arrangement with your EMR. So it varies widely, but typically what we have seen in the field is somewhere between $2,000 to $5,000 to build a single interface. Again, I want to emphasize the word single. So this is an ADT interface or a lab interface and things like that. Attached to it also might be a monthly maintenance fee. Again, our experience shows that some of the EMR vendors also typically build these interfaces for free, but that's not a widely common practice. Jim, let me turn it over to you.
Okay, thanks, Swetha. Yeah, for our experience, Billings Clinic, we are using Cerner as our EMR, and typically when we engage Cerner to help us build an interface, we'll get a quote somewhere between $5,000 and $7,000 per interface. And like Swetha said, it's interface specific. So if you're wanting to do a set of ADT lab results radiology results, transcriptions, ORUs, and immunizations, you would see somewhere around 20,000 for a complement like this. In our situation, we have internal developers that are available to Billings Clinic. So for Billings Clinic and affiliates associated with our system, there won't be any additional costs for the development and deployment of these.
So Swetha, you mentioned earlier that that there are some anomalies depending on whether the provider's EHR system has already been onboarded somewhere else. Can you go back over that a little bit?
Sure, definitely, Jason. Yes. So if a provider's EMR is already connected to Big Sky Care Connect, and this holds true typically for provider EMR, like for ambulatory EMR vendors rather than hospital EMR vendors. But if we build a connection to them one time, most of these EMR vendors like Athena Health, eClinical Work, typically build what is called a hub with the health information exchange. So once that hub is built, it's kind of almost like a one and done thing. There is still testing involved. We should never skip that step, which is very important. There's still testing involved, but the connectivity and the initial setup is done. So that greatly condenses the time. And again, if you are, there are a number of providers in the state that belong to a particular EMR vendor, you can probably band together and work out a cost as well. So.
Okay. So Ayang, the next question is for you, actually. So, okay.
Yes.
So, what does it take to get users set up in the system?
Okay.
And in particular, the portal system.
Sure, I can go over that. So in order to set all of the users up in the Big Sky Care Connect system, we will need them to complete the authorized user agreement. Outreach coordinator assigned to your facility will work with your facility contact to coordinate this effort. And it's up to the organization to decide what the roles of their users will be. And I think we've kind of gone over that. So I've got that listed on the slide here. We have clinician with 42 CFR access and clinician without. Then we have a role for clerical personnel, and then a role for privacy officers who can access those audit reports and break the glass reports, and a different role for payer case managers, as payers are only limited to look at data for their eligible members. So once Big Sky Care Connect receives all the completed AUAs, all of the accounts will be set up by our help desk, and then users will receive training before we go live.
Okay. Let's move on to the next slide, please. Time and resource commitment for participants. We talked a little bit about this earlier, so let's hit this one quickly, leave a little time at the end for questions. What resources, Tim and Swetha, what people that are listening to this, what should they plan on for resources for onboarding?
So for resources for onboarding is a very good question. So if you're a hospital kind of a provider, because we'll have a mixed bag of audience here, if you're a hospital kind of provider, I would say at least having one interface analyst dedicated to this project for the time period of the project would be very good. Again, if you have the bandwidth to assign a specific resource to a lab message, or to build a radiology interface, that would be very good as well. The other thing to keep in mind for smaller facilities without integration resources is to make sure you are in alignment with your EMR vendor, or are in constant contact with them to make sure they are assigning the correct resources to the project to ensure the project is moving. Because in these cases for smaller provider practices, typically 100% of the work is dependent on the EMR vendor, and the EMR vendor wants an SOW to be completed. So that is typically their first step before they assign an analyst to the project. But managing those resources tightly and managing the relationship tightly with the EMR vendor is very important. And the time commitment for participants, again, 6 to 8 weeks, depending on how quickly we move.
Jim, do you have anything to add?
Yeah, I would agree with Swetha. The ensuring that you've got somebody in your team that's working with the vendor or your developing team, acting as a project manager is key to keeping everything moving, because there's a couple of different moving parts from the technical aspect of it, of building out the interfaces and testing and validating the interfaces, to redefining your workflow and working with your providers. So there's, depending on the size of the organization, the resources that are available, the number of stakeholders involved can really vary.
We do have a question from the audience. How many interfaces have you built so far? And what EHR systems have you already have interfaces for?
So let me answer that question. So we are working with Sonar currently. We are also working with Athena Health. Sorry, Ayan, were you saying, was there a question?
Meditech? Oh,
Yes.
I was just helping out.
Okay, sorry. Yes, Meditech, and we are also in initial stages of discussion with a couple other EMR. So all in all, we have more than 6 projects in active mode. We are working on multiple interfaces for each of these projects. So we are working on labs, ADTs, radiologies, and CCDAs for each of these provider practices. Like I said, we are primarily working with Sonar, Meditech. There is a vendor's name that I'm trying to think that's not coming to me right now, but Athena Health surely is in the mix. There is an EMR vendor I cannot remember for the life of me right now, but I'll put it in the chat if it comes back to me. I apologize.
What kind of challenges and barriers have you guys run into?
That's it.
And let's make that specific to onboarding. What are the main challenges and barriers that you have for onboarding?
If I answer the question, that would be mostly lack of participation from the EMR vendor side. So we are facing huge issues with not getting resources from the EMR vendor, whereas for these smaller practices, that means we cannot even kick off the project and start the project. So
again, I guess that would be the importance of having someone from the provider practice or the hospital, or that organization has to direct and manage the EHR vendor, because they just won't respond to the voices of the HIE. Correct?
that is correct. And a good reminder in here would be that the EMR vendor has a relationship with the practice. Okay, they don't have a relationship with the HIE. So they're not even bound to respond to the HIE unless it's a formal project in place. So the first initial contact and the first initial subset of meetings, it's very important that the provider resource, whoever's managing this project, tightly manages the EMR vendor resource till the project is at least lifted off the ground, I would say. I agree with you 100%, Jason. Yeah, that is the biggest barrier we are facing right now.
So there's a question from the audience asking if there is already an interface with Epic.
I don't believe we have an interface already with Epic. But having said that, I also want to remind that Epic is a hospital EMR, and it's always one interface is one interface, meaning Epic will not build interfaces in a scenario where, hey, we are building this hub, so we are doing one hub for the state of Montana. Epic will not do that because Epic is a bigger vendor, hospital vendor, and typically most of these hospitals would be on different versions. So each connection is a different connection with Epic. So I want to emphasize that. Having said that, no, not yet. I have built interfaces with Epic in my previous life, not yet here in Montana.
Kevin, I assume that InterSystems has built plenty of Epic interfaces.
That is correct, and multiple different types of connectivity as well. We've done a single sign-on with them. We've also done document exchange, so where it's an XCA integration with them, and we've also done good old-fashioned HL7v2 integrations across all their transactions. So yeah.
Okay. What advice do you guys have? And we'll start with Jim and then go to Swetha. What advice do you all have for those who are interested in onboarding with Big Sky Care Connect to help them have a smooth and successful experience?
Okay, thanks, Jason. From our experience at Billings Clinic, the biggest advice I could say is make sure you do your due diligence during the data validation phase. A lot of times, once the interface is built and the data is flowing, a lot of people will sign off on it. But until you've actually had your subject matter experts reviewing the data and comparing it to the EHR and confirming that all the data is where it's landing the way it's supposed to be landing, you're not done. And if you don't do a good job during the validation process, you'll find out later, but by then you'll be up and running, and the amount of rework is painful.
Swetha, what would you add to that to help make the onboarding go well? How do people prepare for that?
Managing your contracts with your EMR vendor very tightly is probably going to be the most important step. Along with, I would emphasize what Jim said as well. Yes, validation is highly critical when you're building these interfaces. Engagement with your EMR vendor and testing, basically.
Okay, so at this point, we're going to open it up for audience questions. Do we have audience questions?
Jason, we don't at the moment. So do you want to start with some, maybe a question on medication history?
Sure, we're either very thorough or very boring. Yeah, so let's talk about medication history for a second. How does the medication history work within Big Sky Care Connect? Now, well, does a provider have to exit and go someplace else? Take us through that and tell us how that works.
So for medication history, I'm happy to report that we have partnered with Dr. First. So no need to log into a different place, no need to go anywhere else. Right from the portal itself, the entire medication history would be visible. And the provider need not do anything extra or special. So the way it works is behind this. So as soon as there's a patient search, behind the scenes, we trigger a query to Dr. First and we get that information back and show it in the portal. So the provider is, whoever's using the system is not doing anything additional except for searching for a patient. So it's a seamless integration of sorts, but all the medication data that you would be seeing is going to be a medication history from Dr. First. We also have medication data from Medicaid as well that would be intermixed into that, but we would be showing where that data is coming from. So the source would be very clear as to if that is from Dr. First or if that data is from Medicaid.
So if I do the direct query, access the system, pull down my CCDA, I've got a medication list, allergy list, immunizations, problem list, physicians, encounters. Am I free to parse that and import that data into my system?
Yes, you are at that point free to parse and import that into your system. Basically, again, that completely depends on your organizational policies on how you want to handle that data. Big Sky Care Connect is delivery to the door. Again, I'll use that term because we only deliver it to the door. Beyond that door, how you want to use that data, how you want to digest that data completely depends on your organizational policies. But yes, you can. And that is the beauty of the CDA, right? So it's a common denominator. Most every EMR system understands a CDA model and has the ability to ingest that or even actually to show that or ingest that. So.
Okay.
We do have a question. Are you working in interfaces to PBMs?
Pharmacy benefit managers, I assume that means, so pharmacy processors?
Not at this moment. No, we are not working with any PBMs directly.
But you are getting the Medicaid pharmacy claims, correct?
Yes, but we are getting the data from Medicaid. Yes, but you're absolutely right. For that purpose, we are getting the data from Medicaid. Yes. We are working with Medicaid on that.
So they're working with one PBM. I assume the Medicaid program there has a pharmacy benefit manager.
I'm not overly familiar with the Medicaid process in Montana, but I do know that they are sending the medication history. So I assume they have a PBM, yes.
Does that answer the question, or is there a follow-up question to that or discussion?
I don't see anything in the chat at this time.
Okay.
I do want to provide the audience with some contact information. We have outreach coordinators that work with Big Sky Care Connect, myself included. I'm a young Huff here. So if you have any further questions about any of the topics that we covered, you are welcome to reach out to any one of us here on the slide, and we will get back to you with information.
Thank you to all of our participants in our panel and to Big Sky Care Connect for providing this forum, Ayang for coordinating, and our wonderful tech support, which nobody got to meet, but has made me feel confident for the last hour and a half. Thank you very much.
Thank you all for joining us.
Thank
Have
you.
a great day.
Thank you. Take care.